Now next up, we have disorders of galactose metabolism. Now in galactose metabolism, galactose is converted into glucose so that it can be used in glycolysis. Now most of this takes place in the liver, but other tissues also metabolize galactose, but to a lesser extent. Now normally, dietary lactose is broken down into galactose and glucose. Next, galactose is then phosphorylated by the enzyme galactokinase to produce galactose 1-phosphate, which is converted by uridyltransferase to glucose 1-phosphate. Now glucose 1-phosphate can be converted into glucose 6-phosphate, which can be used to start glycolysis or finish gluconeogenesis, depending on the energy needs at the time. So what happens if you're missing some of the galactose metabolic enzymes? Well, galactokinase deficiency is an autosomal recessive deficiency of galactokinase. This prevents the phosphorylation of galactose and instead causes it to be converted to the alcohol form, galactitol. Now this is catalyzed by the enzyme aldose reductase, which is the same enzyme that converts glucose to sorbitol. Now a galactokinase deficiency is usually a mild condition, but galactitol does accumulate inside cells and can cause galactosemia, infantile cataracts, and the failure to attract objects or develop a social smile. Now how does it actually cause galactosemia if we just said that galactitol accumulates inside cells? Well, think of it as clogging up the sink. If there's nowhere for the ingested galactose to go, it will accumulate in the serum and then also be excreted in the urine. Now classic galactosemia is a more serious autosomal recessive deficiency of galactose 1-phosphate uridyltransferase. Now a deficiency in galactose 1-phosphate uridyltransferase causes galactose 1-phosphate as well as galactitol to accumulate inside of cells, causing some of the same effects as galactokinase deficiency. Now some of the effects you can see here are infantile cataracts as well as some new signs due to galactose 1-phosphate accumulation, and these include jaundice, hepatomegaly, and sepsis in neonates, particularly with E. coli. And can you think of why neonates are particularly susceptible to sepsis secondary to E. coli and galactose 1-phosphate uridyltransferase deficiency, or classic galactosemia? Well, the exact mechanism here is unknown, but it's felt to be due to several factors. First off, the accumulation of galactose in tissue, as well as in the blood, leads to a dysfunctional immune system. Also, the extra galactose provides a substrate for the E. coli to grow on, as E. coli here is a lactose fermenter, and remember that lactose is just galactose plus glucose. And finally, infants with classic galactosemia often have lots of GI issues when they're fed lactose or galactose-containing products, and this can result in significant vomiting, which may predispose the infants to translocation of gut bacteria, particularly E. coli. Now these effects are similar to what you see in fructose intolerance, since in both cases you're accumulating a phosphorylated monosaccharide inside of hepatocytes, causing liver damage, and also leading to loss of phosphate stores in the process. Now the treatment for classic galactosemia is pretty simple. You just don't eat anything that has galactose or lactose in it, which once again, lactose is just galactose plus glucose. Alright, now let's take a shot at a board style question. A 6-month-old boy is brought to the physician because he seems smaller than the other kids his age, and he has occasional vomiting associated with bottled milk feedings. He was born at home and did not undergo any newborn screening, and on physical exam, the patient is found to have jaundice, bilateral clouding of the eye lenses, as well as hepatomegaly. The patient also shows signs of developmental delay. Which of the following enzymes is likely to be defective in this condition? Is it A, alpha-1 hydroxylase? Is it B, aldolase B? Is it C, galactose 1-phosphate uridyltransferase? Is it D, iduronate sulfatase? Or is it E, transmembrane copper transporting ATPase? Think you know the answer? There you go. The defective enzyme here is C, galactose 1-phosphate uridyltransferase. The question prompt here gives us all the information we need to figure this one out. Here we have a 6-month-old with vomiting after bottle feedings, as well as jaundice, lens clouding, hepatomegaly, and developmental delay. With all of that in mind, hopefully you're thinking of classic galactosemia, which is an autosomal recessive disease due to deficiency in galactose 1-phosphate uridyltransferase. That there are essentially 2 galactose metabolic disorders that you'll need to remember for your test. The milder form, which is galactokinase deficiency, may present with infantile cataracts, but usually not developmental delays because of its benign nature. So with that in mind, you're much more inclined to think classic galactosemia if you see developmental delays. Also remember, in classic galactosemia, galactose 1-phosphate, as well as galactitol, will accumulate in organs causing damage, and this can lead to jaundice as well as hepatomegaly. Also notice that the question said that there was vomiting that primarily occurred after milk feedings. And once again, milk has lactose, which is a disaccharide that gets broken down into galactose and glucose. And what do you think the treatment would be for this kid? There you go. It's just a galactose-free diet. And real quick, just to cover the other answer choices. Answer choice A here, which would be an alpha-1 hydroxylase deficiency, can be seen in vitamin D-dependent rickets type 1. And here you'll see early onset rickets as well as hypocalcemia. Now choice B, which is due to a defect in aldolase B, is seen in hereditary fructose intolerance. And here you're going to see hypoglycemia, vomiting, jaundice, as well as cirrhosis. And it's due to an accumulation of fructose 1-phosphate, and you're going to also see decreased phosphate levels. Now answer choice B, which is due to an ironidate sulfatase defect, it's seen in Hunter syndrome. And answer choice E, which is due to a defect in transmembrane copper transporting ATPase, is seen in Wilson's disease. Well, alright, that's going to wrap up galactose metabolism. See you in the next video.